carcinoma, MEN2, kind of unusual diseases that can affect the thyroid. And again, there are some GLP-1 receptors on the thyroid, so that's why they have that. Side effects, again, GI, or nausea, diarrhea, vomiting. And again, you're slowing down the gastric emptying, and you have the potential to get these other problems. Again, it's all during the dosing, just slow it down. These are more what I call tolerability issues, not safety issues. Naltrexone, bupropion, thank you. Naltrexone and bupropion, they can raise blood pressure. And it's mainly believe it or not, the bupropion, not the naltrexone that's doing that. And it's funny, they don't have this warning when you use it for cigarette cessation, which I find interesting. But anyway, if somebody has a seizure disorder, you don't want to use it because bupropion, because it's an uptake inhibitor of norepinephrine and dopamine, can make someone at risk for seizure disorder. But again, when you look at the side effects, it's all GI. It's funny, and that's probably the naltrexone. When we were studying this really early on, we saw with the immediate release naltrexone, unacceptable nausea and vomiting. But again, nausea, constipation, headaches, they kind of happen there. Phentermine topiramate. Phentermine is a stimulant, so you get all the things that come with stimulants. Topiramate is an unusual drug that gives you, it's a carbonic anhydrase inhibitor, so you can get paresthesias of the hands. Some patients just feel off on topiramate. They don't, quote, think as well. So again, look for all that stuff. Use the lowest dose you can. Orlistat, old drug, been around for a long time, just blocks the absorption of fat. So expect some of those types of side effects, oil leakage, oily spotting when they pass gas, things like that. Setmelanotide, surprisingly no contraindications, but brand new drug. And you're saying skin hyperpigmentation. You got to remember that when you're firing the system of the brain that works on the MC4 receptor, it works through the MSH or melanocyte stimulating hormone. So you see skin hyperpigmentation. Whether this is normal, I don't think so, but it's not abnormal. And again, I don't know how to tell you this because, again, these patients will be fairly light-skinned when they start, and then their skin will darken up. Headaches, diarrhea, kind of the usual stuff. A potential, again, when you deal in the brain that deals with fullness and food, for some reason you can get spontaneous erections. So again, that's a potential. Again, very, very rare. And then Gelsis 100, which is again the super absorbent hydrogel. When you eat these 3 capsules, you drink a bunch of water and they swell, you can get kind of this, full feeling really quick. And patients interpret that differently. Usually I hear bloating is what I hear from patients. And it may give you a little more gas or constipation or diarrhea. So again, everybody's different.
Well, thanks, Ken, for a great review of pharmacotherapy as well as devices. Again, I would encourage all of you to do more reading, increase your competence and familiarity with these drugs. We'll talk about this a little bit more during the Q&A, but they're underutilized in patients who would potentially benefit from more aggressive treatment and lifestyle. So, Ken, thanks so much for giving an overview. Now, before we get into our Q&A session, here are our SMART goal takeaway points. Now, SMART goals are usually used for patients when we talk about behavior change, but I'm going to apply them to you, our audience, regarding takeaways. And here they are. Encourage patients with obesity to get fully vaccinated for COVID-19. That's ongoing, and we still need to do more vaccination, not only in this country, but globally. Ensure equitable clinical interactions with all patients and avoid stigmatizing language. Apply the 6 A's model for weight management counseling that Fatima went over. Partner with patients and employ shared decision-making to improve adherence to therapies and improve outcomes. And lastly, what Ken went over, prescribe therapies for weight loss when indicated that consider energy balance dysregulation and the underlying biologic metabolic adaptations to weight loss. So let's now get started with our Q&A. To ask a question, please click on the Ask Question tab and type your question. Please include the faculty's name if you want to, or we'll just go ahead and take it ourselves. So I'm going to ask Fatima and Ken to join me here. We have a whole series of questions. that I'm going to ask, and I'll feed you guys, and I'll jump in myself as well. Fatima, I'm gonna address this one to you first, and that is how does a primary care clinician do a competent and adequate job in obesity care in a crowded office visit, which is often 15 minutes? What do you tell the primary care provider?
Absolutely. I think that's an excellent question, Bob. And I think the key thing is that we know that your time is limited. And so you may need frequent visits, which is exactly what we want when we're working with patients with obesity anyway. So maybe you do a portion of all of those things that I said at one visit. Maybe you do another portion, another visit, and another portion, and another visit. So 3 full visits. But that allows you to engage with the patient. And I think that you start to build up trust. A lot of times there's a lot of distrust for patients with obesity with their physicians, and showing that you really care and want to do a thorough job, I think is what you will find if you get a chance to do that in kind of small bite-sized pieces, for a lack of a better way of saying it. So that would be my strategy if I were primary care doing this. I'm very busy primary care, doing bits and pieces and then building upon each other, developing that comprehensive strategy for the patient.
Yeah, it is challenging. I often talk about setting up a separate visit, and prior to coming in, have them track their diet, have them prepared for the, chronic care model. Be prepared, both patient and physician, to do that adequate job. So it's very, very challenging. Thanks, Ken. There's a question I want to toss to you, and you went over very nicely. The different medications are available, including a device, the Gelesis device, which is a capsule. How are clinicians supposed to decide which one of these to choose if they want to become more aggressive with their patient?
Wow, that's a tough one. So, and what I'm about to say probably would be considered off-label, but if you want to be aggressive, just use your standard skills. In other words, if they have cravings, okay, maybe I might use something that addresses cravings. There are several studies on some of these that actually show they work very well in cravings. The other one, and again, this is part of the future, you may have to use 1 or 2 or 3 medications to help lose weight, just like type 2 diabetes. Now that's being the most aggressive, and you really want to be well-versed in these medications, especially their side effects and interactions with other drugs. But, picking the right one is always the hardest. And I wish, and Bob's worked on a ton of these guidelines, and we don't have enough data to tell us which one to use. It's just been a real hit and miss thing. I have one thing to say also to what Dr. Stanford and Dr. Kirshner were saying about how in a busy practice, how do you do it? And I'm maybe not as busy because I'm near the end of my career, but I'm really lazy. So what I do is I farm a lot of my things out. So one is I use dietitians a lot. Dietitians are great. They believe me, they can really answer a lot of nutritional questions, which can take up a ton of time. The other one is I will use commercial programs as well. And I don't get any stock or own anything in Jenny Craig or Weight Watchers, but those are 2 fairly good systems that most patients have access to do. And if, say, you're adding in a medication to that, you get outstanding weight loss.
Yeah, that's a great point, Ken. I'm so glad you brought it up. I use the term team sport. Obesity is a team sport. You don't have to be, you could be quarterback if you want, but it's still a team. And we're not dietitians. We're not health psychologists. We're not intensive behavioral therapists. At least we don't have the time, even if we often want to. So you make such a great point of bringing in the team, assessing a patient like Fatima talked about, and assessing for additional needs and resources. That's so darn important. Fatima, do you want to weigh in on that as well? It's such a good point.
Yeah, no, absolutely. I'm obviously, in obesity medicine in a comprehensive center. Thankfully, I have a lot of those people in place. And so I wanted to address it from the vantage point of not having 4 full-time psychologists and several, 4 full-time dietitians and et cetera, et cetera. So I do want to be mindful of the fact that I recognize that resources can be limited in some settings. And you may find that those things can't be done in the context of just what's happening in your office. But I think that Ken brings up a important point. Now, when I talk about this team sport, I always tell my patient, they're the star player and I'm the coach, right? I can't do anything without them showing up and doing their best job, And so that really gets them to think about it. in a way of like, oh, wait a minute, I'm the star player. I need to show up and I'm really the supporting cast. But I said, I can coach, but if the player or the team doesn't show up, then I can, the game doesn't get played. And I really think of, using, these analogies to help you with your interaction with patients really goes a long way in setting up great rapport.
Yeah. The medical terms would be patient-centered care and shared decision-making. I think you elaborated on it so much better that people would understand taking those medical terms and actually applying it. Fatim, let me come back to you with this question, and Ken may want to weigh in as well. There's a question about a patient comes in, wants to address his or her obesity, their weight. They've been around the block a few times. This isn't their first rodeo, right? They've tried they've tried a diet. They may have even seen a registered dietitian. Can we talk about using medication on that first visit, or do we say, you know what, let's like reinforce what you've already done, like show me that you could do it and you know what you're doing. Then we'll talk about medication. Or can you jump in medication right away? How do you sequence that?
Yeah, I think it, depends on what you feel comfortable with. But I think that we do a disservice to patients with obesity when we don't begin to consider medications, sooner. We don't have a patient come in with diabetes and say, you know what? I see that hemoglobin A1C is 9, but you know what? Go and eat less, exercise more, and come back, right? That would be inappropriate. We would lose our license. We don't do that with hypertension. We don't do it with anything else. And so I really think that we need to be mindful. When Dr. Fujioka presented those results and looking at the medications and looking at the response that we can get, the range of response, I can tell you that can be extremely encouraging for patients. And for those patients that have been around the block, many of them have some of those building blocks with regards to diet quality, right? Physical activity, they have those in part, and they find that, look, their body is just resisting movement down. And so those medications are working on those different pathways of the brain that we talked about to change how their brain sees weight. And so I can tell you today, I saw patients right up into the moment I came on camera, and I had patients that were responding to medications, half of the combinations that Dr. Fujioka pointed out, and just to see the smiles on their face and to see how encouraged they felt after 55 years of never being able to have any measurable change. It really, it brightens my day. I think sometimes more than it brightens their day. So I really want us to be thoughtful and mindful about how we have that stigma against avoiding therapy and making the patient work for it when we don't do that with anything else.
Mm-hmm. There was a bunch of questions on this metabolic adaptation, the first part of the talk that I gave about how long does it last and so on. And I just want to highlight just a few things. To me, it really speaks to the biology of obesity and what is going on there. And there's clearly a role for foundational lifestyle changes, diet, physical activity, don't smoke, don't use alcohol excessively, sleep, stress, and so on. But those metabolic changes, as far as we know, are long lasting. 6 years in the Biggest Loser contest. And other studies in the clinic and as well as in research centers have shown that they last long as well. We have two biological interventions that seem to have an impact on that metabolic adaptation. One is pharmacotherapy that Ken went over, and the other is bariatric surgery, which we didn't get a chance to talk about today. But it speaks to the biology of this chronic relapsing disease and what we could actually do about it, in addition to lifestyle, of course, which is foundational. Ken, I want to turn to you. There's a lot of questions on semaglutide. I think it's because it's the latest kid on the block, and you went over the 4-step trials and so forth. But the kinds of questions we're getting is, can a PCP prescribe semaglutide, or should it go to a specialist? How long can we keep someone on semaglutide? What's the longest data we have on semaglutide? So, as well as cost and coverage. Can you answer some of those questions for the audience?
Sure. At my age, though, that many questions, I'll forget half of them by the time I get even through the first one. But, first off, if you're primary care, please feel free to use it. It is, I like it because it's a drug. It's an injectable. And I know some primary care docs don't feel comfortable, but most are quickly becoming very adaptable. It's sub-Q, it's easy to do. And they'll just send you the boxes and you do it. And the only part you need to do as the primary care doc is just make sure you titrate it slowly so they're not getting too much nausea, because it's going to work. And again, at least a third, 40% are going to have nausea, and you just need to slow it down and they're going to do great. And you will just slowly creep up over months. I mean, it may take you 6 months, 8 months to get to where you need to be. How long do you give this? And again, Bob just brought this up. You're fighting biology. So you really think of this as a forever long-term drug. Now, whether they'll be on this one forever, no. There's just too many good things coming out. And there'll probably be some kind of injection in 5 to 10 years. They'll just do once a month, and it'll kind of help out these hormones to, I hate to use the term reset, because as far as we know, the hypothalamus never resets. Once whatever the highest weight it thinks you're at, it stays at that forever. But at least tell the brain it's okay to stay at this lower weight. Bob, you had like a couple of other questions.
Well, you maybe want to just touch briefly upon this whole idea of reimbursement and cost, because the most vulnerable population, unfortunately, often doesn't have insurance coverage for many of these medications. I wonder if you had some comments just about the coverage that we're seeing and where that direction is going.
Okay, so I'll start with the last part. The direction is going, we're going to see more and more coverage, and that's been shown over the last about 4 years now, which is just huge. And who's covered? This is a really odd question, because it really comes down to whoever their employer is. If their employer opts in on their insurance to cover weight loss medications, they're home free. And that's about, if you just went across the US, about a third of your patients. Now, in some places, say Texas, say the Carolinas, it's like 80, 90%. So again, it's very different from state to state. And I don't know why that is. In California here, we're roughly right around 30%. So again, it depends. What's really odd to me, so I've never seen Medicare cover it, but Medi-Cal or Medicaid, as it's called in some states, actually covers it in California. So again, I never can figure out who it's covered for. And quite honestly, I'm pretty lazy. I just write it and send it in. And again, on the cost issue, yeah, if they've got to pay for it, they're looking at about $1,000 a month. That's out of the pocket of 99% of my patients. So again, they're really looking for coverage. And the only way I know to find out is just send it in on my EMR and see what goes on. And if it's covered, if I do a prior auth, okay, I write out the prior auth and send it back. And again, it can be tough for some patients because they'll be good candidates, but it won't get covered.
Yeah,
I have
thanks,
some
Ken.
thoughts on that, Bob,
Please,
if you don't
please.
mind.
Mhm.
So, I, as someone that really spends a lot of time in Capitol Hill, I'll be speaking with Pelosi's team next week. A lot of the coverage issues come down to what does Medicare cover, because the private insurers, the employer-sponsored insurers, follow Medicare. So we've been trying to get through, and the three of us, along with others, have been trying to get through Congress, both the House and the Senate, TROA, which is the Treat and Reduce Obesity Act, which would cover both behavioral therapy, so work with dietitians, for example, for obesity, but also pharmacotherapy for patients with obesity in the Medicare population. What I can tell you when we're looking at Medicare is that Medicare does not cover a lot of these agents. Many of these, as you could tell, the drugs that Dr. Fujioka presented, many of them are combinations of things, and we may use the generics for patients to make sure that we're using them. Obviously, the GLP-1s at this time, particularly the ones that are approved for the treatment of obesity, are not yet at a generic level, meaning, there's still several years left, for example, for liraglutide to come off label. For me, I work with a lot of patients that are under Mass Health. Mass Health is what became the Affordable Care Act. Those medications are not covered also under that domain. So you have to be creative in using some of the agents that you can see, combinations of meds that you're familiar with your use in the primary care setting. That is what I've done to ensure that my patients do get access to pharmacotherapy. But I would say for each of you that are listening, to really advocate for TROA. We've tried for 8 years to get this through Congress and have strong bipartisan support, since obesity is not preferentially target one political party, but we have not yet got it across the finish line. So we need more voices out there.
Right. Fatima, thanks so much for jumping in there. That's just great information to get across. I want to go back to one of the questions about, do you have to be a specialist to prescribe these anti-obesity medications? And the answer is no, of course you don't. Currently, only about 3% of individuals who are candidates for medication receive a medication. That needs to change. I always say clinicians need to be part of the solution, not continue part of the problem. So we need to increase competence and familiarity. However, if you do see a patient with a complicated case of obesity, or you don't feel you're able to handle that patient, I do want you to know that there is the American Board of Obesity Medicine, the ABOM. And if you're interested in becoming identified as an obesity specialist or wanting more information regarding it and take a certification exam for that, you can go to abom.org, and that's just very helpful for you to be aware of. Fatima, I want to come back to you. There's a question here, which is a very practical question, and we need to answer it. The question is, what lifestyle changes do you use with patients? So let's go back to that, 5-10 minute drill with a patient, right? 15-minute thing, and you set some time aside. How do you prioritize? And you could use the 6 A's, which is a great framework that you went over. Yeah. But what should we really be prioritizing in our limited time with patients about lifestyle change?
Absolutely. That's a great question. And I think you have to listen to what the patient struggles with, but the key big areas are looking at diet quality. I think that, severe caloric restriction and having to do, elimination diet, these aren't sustainable over the life course. So we want things that work within their life course that they can sustain indefinitely. We want to prioritize lean protein, whole grains, fruits, and vegetables as our predominant source of intake, and fit that with the patient in their cultural setting, however that needs to work. That's what I want to think about. Activity, which is my favorite thing to talk about. Actually, I would be working out now if I was not doing this, is you want to talk about at least 150 minutes of moderate intensity physical activity per week. But with patients with obesity, the target is actually somewhere around 300 minutes of moderate intensity. And that's mostly for weight maintenance. We know physical activity doesn't typically drive a significant amount of weight loss. I want to prioritize looking at quality and duration of sleep. I think that's important. You want to evaluate the patients. This is something you brought up, Bob, earlier, medications that may be weight promoting, leading to weight gain, seeing if they're needed. If not, withdrawing those. I think that these are really some of the key elements that I bring up with like every single patient, but I'm listening to the story they're giving to decide which one I need to emphasize first, because addressing all of that once will lead to disaster, right? You're going to start in a graduated fashion. And I think starting with diet quality, which is where I started in this answer, is where I typically will set my sights as the first area of interest.
Mm-hmm. Great. I agree really completely. It's challenging. And I always tell my medical students, residents, and physicians, have the script in your head. If you're jumping into a patient care visit and you haven't really have your script in your mind of what you're going to go over, like everything you just said, Fatima, you're going to be struggling. So be prepared to talk to the patient and have that script or narrative that you're actually going on. So I'm going to go ahead and flip to the end here. And I want to thank you all for your time today and esteemed colleagues, Fatima Cody, as well as Ken Fujioka. Thank you so much. Fatima Stanford Cody, sorry. Thank you so much for helping out today and for our audience. To receive CME CE credit, click on the Request Credit tab to complete the post-test and evaluation online. Be sure to fill out your ABIM ID number and date of birth, month and date only, on the evaluation so we can submit credit to the ABIM. You can print your certificate or statement of credit immediately. To claim CME credit as a MIPS improvement activity, complete the activity post-test and evaluation at the link provided. Over the next 90 days, actively work to incorporate improvement in your clinical practice from this presentation. Complete the follow-up survey from CME Outfitters in approximately 3 months. CME Outfitters will send you confirmation of your participation to submit to CMS attesting your completion of a CME for MIPS improvement activity. And don't forget to visit the Virtual Education Hub for free resources, including the animated features you saw today. Once again, thank you for attending today, and thank you for the staff for helping out. Bye-bye.